So we shall now go on to our next speaker, a very dynamic person, Dr. ARULMOZHI, who is the chairman and medical director of UMA Eye Clinic, Chennai, a greatly astute surgeon, a pioneer in phaco emulsification in our country, a driving force to keep all the latest technologies of cataract surgery at the forefront. And he is going to tell us about how to be precise in a refractive cataract surgery. On to you, Dr. ARULMOZHI.
Thank you, Dr. Chitra. You can hear me?
Yes, yes.
Yes, fine. Thank you so much. So everybody wants to do a perfect cataract surgery, particularly when you have these advanced lenses where you don't want to go off and have the patient eat your head because he's paid you a large amount of money and he's not happy with the outcome. So it starts with biometry. I think that's been all covered. I'll just go through it for sake of completion. You do a good biometry, you do the right calculation, you choose the right IOL. Then that comes to that last little finishing touch, the surgical technique. So it's a combined effect that starts preoperatively and then goes on right up to the surgical steps and also eventually postoperative follow-up of the patient. So just no amount of emphasis can give the importance of good biometry where you need to do a perfect keratometry, get a good AC depth, white to white, lens thickness and axial length. All of these can be got off even from an ultrasound biometer if they're done properly. If you have access to a SSOCT based biometer, nothing like it. So the keratometry is the most important point. Most of us think it is axial length. I'm sorry to say, I think keratometry is the most important reading that gives you the maximum number of errors. You can do a good manual keratometer. Autokeratometer is fantastic. The newer telecentric is superb. Nothing beats it. A posterior K with a true K really puts the cherry on top of the cream, and then you get the perfect results. The topographer, yes, when would you use it? When you really want to know the axis on placement of the toric IOL, or when you want to really know the toricity to calculate the toric IOL a little better. In all situations which are abnormal, like post-LASIK, post-RK, a keratoconus or a highly irregular cornea, a topography is extremely important. We need to know not only just the axial length, we need to know the ACD, the lens thickness and white to white. All of these can be read off manually. If you have an automated instrument that gives you all of these, well and good. Strepsod OCT would be the best, is the gold standard now. It doesn't mean that you throw out your ultrasound biometers. You can work with them too. White to white can be taken off with just a vernier caliper. Formula, today's formula, which is available off the shelf, would be the Barrett Universal 2 Toric. Put all your calculations on the Universal 2 Toric platform and then go by what it says. Don't believe just that there's a low astigmatism or low K value, you don't have much of a toricity. Go by putting this the calculations into the Toric platform. And if the Barrett Universal 2 Toric tells you to put a Toric lens, put it in. Of course, newer formulas such as Kane and Evo are on the offing. Let's wait for that. Of course, then you choose the right IOL. Whether you want to put in a toric IOL, a multifocal, a need-off, an aspheric, or sometimes you choose to put in a spherical lens. When would you put a toric IOL? If your corneal toricity is more than 1 diopter, I strongly recommend putting in toric IOL. Yes, can you do a LRI and get away with it? LRI works well in low astigmatisms, but in anything more than 1.5 or 2, I would strongly recommend a toric IOL. You put in a toric IOL, marking becomes very important. Manual markers are still very accurate. Yes, a markerless system is fantastic, takes out a lot of guesswork, but a properly done manual marking is as accurate as the most advanced markerless system. Then we come to the surgical pulse. First thing is that your incision has to be astigmatically neutral. Doing all your calculations and doing a bad incision that induces astigmatism or changes the axis of astigmatism can be catastrophic. The CCC should be central and properly sized so the lens stays inside the bag, does not pop out, does not tilt, does not rotate, will not go into a capsular bag contraction syndrome. And of course, you should align the IOL properly at the end of surgery. If the postgraduates who are want a single slide that takes the most important slide, this is it. So get a perfect phaco, you need perfect aseptic preparation. Povidone iodine over the lid and the lid margins. Povidone iodine in the conjunctiva, proper draping, isolation lid margins. You can do everything perfect and go wrong here and have a catastrophe. So please do not forget this simple step and then go to the more advanced ones. Incision should be as square as possible, ideally temporal, because temporal incisions do not cause any kind of an astigmatic induction. It has been proven by multiple studies that you can go up to 2.6 millimeters temporal incision that's placed posterior limbal and as square as possible will induce astigmatism as low as 0.12. So my advice is to go for a 2.2, 2.4 posterior limbal placed temporal, ideally square incision. How do you get as square as possible? Use a marker. This is a marker which gives you a mark on the cornea that's about 1.25 millimeters. So you make a groove at the limbus, posterior limbal, and tailor your incision perfectly 10 times out of 10. Dimple in there. So you get approximately a 1 millimeter length to 1.25 millimeter length, which is brilliant for astigmatically neutral. CCC should be again central, ideally sized. It should be about 5 to 5.5 millimeters. Well, we have access to a femtosecond laser, nothing like it. You can get the best incisions and best CCC. But how do we go about it? Again, use a marker. You can use a 5 mm marker, mark it centrally on the cornea. This mark is quite visible. And most important, use the right viscoelastic. It is worthwhile spending that little bit of money extra. Use a soft shell technique that will be very kind on your endothelial cells. So you can still see the mark that you made on the cornea, and that can be used as a template to make a perfectly centered and perfectly sized capsular axis. Of course, if you have access to a markerless system, nothing like it. So again, perfect phaco, you use an appropriate viscoelastic. It's extremely important. A soft shell technique goes a long way in giving you a good, quiet, and happy cornea. Ideally, a dispersive during phaco and cohesive during IOL implantation again goes a long way in giving you excellent outcomes postoperatively. In the bag phaco is very important to avoid endothelial decompensation. Where you cannot do complete in the bag phaco, come out in the iris plane, avoid doing in the anterior chamber phaco as much as possible. So this is again using the marker. This is a different kind of a marker again. The complete surgery. Appropriately place side ports which don't leak is very important to give you a safe surgery. The right viscoelastic in and the marker that you can see on the cornea, or you can use a markerless system to make a perfectly centered axis. Decompress before you do hydrodissection. Do it in the right plane. You would find that you have hardly any cortex to remove at the end of surgery. You can choose any kind of a technique of phacoemulsification, whether you can do a straight chop as I do now, a stop and chop, a 4-quadrant technique. It hardly matters, whichever you're comfortable with. But again, remember the basic premise that do everything as much as possible in the bag. Don't come out outside the bag. Use appropriate energy settings. Do not stretch the wound. Don't make the wound floppy at the end of surgery, which can induce astigmatism. Most of this work is being done in the bag and whatever last bit at the iris plane. A good IA, taking out all the cortex.
Sir, you have 1 minute remaining.
Yeah, and so under the cohesive, and where you're using a toric lens, yes, if you have access to a markerless system, it's very good. But believe me, manual marking is as accurate as advanced markerless system. So Phaco is meticulous attention to biometry, formula, charge of IOL, meticulous surgical technique. Most important, don't not pound on the asepsis. It's extremely important that you don't get into any catastrophes. Thank you.
Thank you very much, Dr. Arul. I mean, you covered every single point. This is a question. I don't have any question for you, but just one question which is there in my mind. I want my panelists to think and answer. I myself need the answer. What is the role of total keratometry in normal versus abnormal eyes, atypical eyes? Now, is it that it's because of the total keratometry we are doing better in the atypical eyes? Or is it that the IOL formulas are so planned and specific for these atypical eyes that our results are better?
Simple. The most advanced formulae require total keratometry to arrive at the most accurate IOL power, be it a normal cornea or abnormal cornea. The advantage of Barrett 2 toric calculator is that when you do not have access to a tomographer, you don't have a posterior K, it assumes it. It asks you as to which machine that you use. Is it manual or auto K? Asks you to give in 2 inputs from 2 different instruments and assumes the total, the posterior K, and arrives at an assumed total K, which works quite well. But where you have the ability to actually calculate the total K and the posterior K accurately using the appropriate instruments, it does put you into that sweet spot, whether the eye is a normal eye or an abnormal cornea. It does not make any difference. It makes it accurate across the board.
Yes, Namrata, you have anything to add, or shall I go on to the next speaker? I think that did sort of answer our question.
I think you can go to the next. I think there's nothing to talk after Dr. Arul's fantastic talk.
Fantastic.
Thank you.
Fantastic. See, 2 of us said the same.